government sees value in people seeking mental health care when it's needed. Okay, they actually look at it favorably if you are getting mental health care, particularly if you're getting it and it's helping and it's working and you're being responsible, right? So it is helpful because they see it as a responsible activity. And it is not a reason, this is in bold letters on my paper, it is not a reason to revoke or deny eligibility for access to classified information. Okay, so just seeking mental health care alone. But that doesn't mean that every case of counseling means that there is no serious disqualifying diagnosis on the back end, right? But if you go to the clinic for a cold, you're going to walk out healed a few days later, right? If you go for a broken leg, you're going to get healed. Right? Mental health care is very similar that way. You come in, you get help, people get better, and they move on and they keep doing a good job. But occasionally you come in and you find there's cancer, right? And then you're done, right? But that is so rare and incredibly rare, and it's absolutely never the first thing that we jump to. So, if you want to add to that.
So in my career in the Navy, and then since I've been here, I am contacted frequently by security investigators, usually contracted by the government, because someone has answered yes on one of the questionnaires, which I encourage people to answer honestly, because if you have received mental health care and you lie about it, and then government finds out, or the security investigator finds out, then that's a big problem. But if you're honest and you say yes, the security investigator will contact the provider that you saw and ask, the first question is, does the patient have a condition that would interfere with them having access to classified information? Usually the answer, even if they've seen me, even if they've been on medicine, the answer is no. And if I say no, then that's the end of the investigation. And the investigator proceeds on. I don't make a final decision. That's the security clearance people who make the final decision. If I say yes, they do have a condition that would interfere, then I have to say, what is the condition? How long have they had it? What is the treatment? What's the prognosis? But again, that's very rare that I have to go down that line of questioning.
And what is so serious that you might be disqualified? You'll know, because you're going to be messed up, right? It's not going to be a secret to you. Right? If you just can't, if you have a personality disorder, or you have a bipolar disorder, right, which is like you run off to gamble all your money and start sleeping around, and the next day you're super duper depressed, right? That's the kind of crazy stuff that's happening uncommonly, and that would disqualify somebody.
Next question is, since depression can disqualify applicants for the academy, what is the disqualification for cadets, and at what point does depression or anxiety be disqualified?
So the question first is, what disqualifies you as a cadet? Why don't you read the question to the mic for the sake of the video? Does that work?
Since depression can disqualify applicants from applying here, why isn't it a disqualification for cadets? At what point does depression or anxiety have to get to be for you to be disqualified?
Again, I have to answer this a couple different ways, but one is, as a cadet here, we hold you to the standard of a session into the military, and that's the standard by which we hold you to get all the way to commission, right? So you had to get here, and you have to get all the way to commission. You have this 4-year awkward limbo period where you have to maintain the same standard, right? The standard for retention of the cadet at the academy is the same as those for officer enrollment. All right, that sucks, right? And so what do we do with all of you who get broken, you're doing athletics, you have mental health issues and all that stuff in the meantime? And so there's this beautiful statement in the medical manual that I want to read you as well. And that is this: it says, cadets should not be summarily disqualified for commission merely because they do not meet the standards for appointment as a cadet. For provided that they may reasonably be expected to be physically capable of completing a full and effective career in the Coast Guard. Right, that gives me license to waive anything that's going wrong with you, as long as you meet the retention standards for the Coast Guard. Right? So if you can stick around in the Coast Guard and do your job, we'll commission you. That's what that means. So it is disqualifying for a section. And being depressed is not disqualifying for retention, with some exceptions, depending on how severe, how debilitating it is, right? It's not the diagnosis, it's the interference that's disqualifying. Does that make sense? Okay. That was the first part of the question. Can you remind me what the rest was?
The second part is, at what point does depression and anxiety, what's basically the line between retention and control?
So depression and anxiety, those are the bread and butter conditions for psychiatrists and psychologists. Extremely common and extremely well treatable. So come to our attention, we treat you with medicine and or talk therapy, and you get better, then you proceed with your career, you're not disqualified. It's only if someone is either refusing treatment and it's interfering with their functioning, or they've accepted treatment but we can't get them back to a fully functional state. And then we have to proceed to a medical board. I've been here I've been here 4 years now. I have never written on board for a cadet for depression or anxiety. I have for bipolar disorder. I have for eating disorders, extreme eating disorders, but never just depression and anxiety. Again, very common and very treatable.
And while we're on the topic of eating disorders are actually only disqualifying when they interfere again, because just the presence of an eating disorder or a history of eating disorder, once again, is waivable if you're well or well enough to do your job. Does that answer the question? The next question is, would it be possible to give cadets the opportunity to go off base for counseling? I know some people could really benefit from that option, whether it is because they don't want to talk to classmates or they don't necessarily feel that they fit well with the counselors in the clinic. Yeah, we offer services because we want to help you and we want to make them convenient, which is why we are excited to have somebody downstairs. But CG support is for the entire Coast Guard. So if you want confidential counseling outside of the Coast Guard Academy facility, then you can just call the number and get help. And there's no rules about you not doing that. You can even come to us and get a ride if you want to get a ride. You just got to get medics, and please use medics and have bad experiences and tell us about them. I'm not joking. We don't like medics. I'm not encouraging it because I want medics. We're trying to get rid of them if they're not doing their job. Okay. Oh, and TRICARE as well. So you can go directly to a TRICARE counselor, and we can sort of if you need more visits, we'll add more visits for you. But you can refer yourself directly to one of them without coming to us first. That's the only kind of care that you can kind of bypass your primary care provider for.
Sir, can you explain what CG support is?
Oh, CG support, yeah. Good question. CG support, it's not spelled support, it's like CG, Okay, brilliant. Maybe you can pass something to the Corps about that later, but it is essentially a Coast Guard work-life program where they offer mental health care and a variety of other services for things that you need for your personal life and professional life. Okay, that's the very short answer on that.
We're gonna open it up for your guys' questions. Just try to be loud so the camera can get it, or sorry, if you can repeat the question as it's asked. Thank you.
Okay. Yes?
Sir, could you explain the process for a cadet feels suicidal, like what the process going through the clinic is like?
Can I explain the process for what if a cadet feels suicidal and what we do on our side of the clinic?
Yes, sir.
So there's a few different ways to look at that because, and I can definitely explain what we do. There are people who we think are suicidal, like let's say you think are suicidal because they're showing signs, they have conversation, and I think you should trust your feelings, right? You should bring them up and even bring somebody down to the clinic. Now, if somebody is like saying, hey, I'm feeling suicidal, right, that's a little different and should also be taken very seriously. There's a little bit of a differentiation there. I want you guys never to feel like you have to make the judgment yourself about whether or not somebody is suicidal or safe, right? And at the clinic, when they come to us, whether they see Dr. Daly or myself, one of the other providers, or counseling downstairs, like there is a gradient of risk, right? So somebody who's like, yeah, I think about killing myself. Occasionally here and there, and I don't really have a plan, like that's concerning, right? That's serious, actually. And at the same time, that person may be very low risk for actually following through. So we start getting them care, consider start medication, and a variety of things, and then we send them back to Chase. Only if they're safe enough, right? Or we deem them to be safe enough or low enough risk that they're not actively going to kill themselves. And it's a risk, right? We can never predict whether somebody is actually going to hurt themselves or kill themselves. And so that's difficult. It's a very difficult thing. But you can never force someone to get care that they don't want. And there's one exception to that, and that's the command-directed evaluation, which is a paperwork process that involves the lawyers, and then you can mandate that they get care, right? And but if somebody's like, hey, I don't want to do this, I don't want to go to the emergency room, then I have to say, well, do I think you're high enough risk to want to get the lawyers involved here and make you go? And if I think so, and I have done that, then we will do that. But oftentimes that's not the case. Most of the time people are already involved in care. We oftentimes know about people already. They oftentimes are already being treated, and we still can't predict what's going to actually happen to them. But what we do is make sure that we've listened to them and make sure that the risk assessment is low. And we don't carry that on our own shoulders. If we just can't make a good assessment, we send them to the emergency room. But again, it has to be voluntary.
Actually, we can send them to the ER. If they don't, even if they don't want to go, if we feel they're a risk to harm themselves imminently or to harm someone else. We can mandate they go to the ER and get an assessment. And then if, what happens next is the ER physician and the crisis worker make an assessment. If they feel the patient should be admitted and the patient agrees, then they'll be admitted. If they feel the patient should be admitted, but the patient doesn't want to be admitted, they can still be admitted on an involuntary 72-hour hold while they get evaluated for their risk. So, does that help clarify?
So just to clarify some of the difference in answer there is we've had to use a command-directed evaluation for a patient a couple months ago that none of you know about, not within your core. And the lawyer said we had to use it. So we've sent somebody and I've mandated it, but it's sort of this like voluntary, involuntary. But if someone is actually dragging their feet and does not want something, we can make them through that command-directed evaluation. Yes?
Second question, Donald. So, is there an alternative to having someone put in that 72-hour hold in your limit?
The question was, is there an alternative to putting somebody at L&M, specifically at their 72-hour facility?
Yes. So, like, is there an alternative procedure where you
when someone has a
L&M
crisis.
has the best reviews.
Okay, because of the reviews of L&M, is there another option? So I'm just repeating for the camera.
So the other hospital we can use is Bacchus in Norwich. They have a psychiatric inpatient ward. And then there's a standalone psychiatric hospital in Willimantic called Natchog, which is very good also. But the patient has to be voluntary to go there. They don't do any involuntary holds there. So those are the three options.
Thank you.
Does that help?
Yeah.
Yes.
First class involved. So if I were to go to either counseling, advising, or my PCM, and I was having serious signs of depression, and I want to talk confidentially, can you talk about how much my primary care manager can talk with other people, or how much the counselor can talk with other people, and how confidential it is among medical staff?
The question is, when you come to us with concerns, how much do we end up talking to other people about your concerns? Yes, they're within the clinic. Like if I end up going to talk to Dr. Daly about, if you come to me and I talk to Dr. Daly, that's not a release of information because we're considered one entity under the HIPAA laws. And so I don't have to document a release or like request any kind of permission to go do that. We use discretion in the clinic, and I don't just go talking to Corman about a particular person's problem. And particularly when it's mental health care, we like keep tight reins on what you guys end up talking to us about. Whereas if it's other stuff, we'll be a little bit more free to just say, hey, go to lab and do this, and talk to like the variety of Corman that are involved in your care. So if they're within our entity, we do talk. If they're outside of our entity, and that includes your command, then we have a very limited opportunity to share what's necessary to talk about your ability to perform your job, okay? And so we do not talk about the content of the conversation, but there are times where the content of the conversation is a necessary or a relevant piece to why someone really can't proceed with a certain activity. So there's an exception to that too. And then we would document a release of information, but under the HIPAA laws, there's a military clause exception to be able to talk to commands. And there's a memo that was signed by Admiral Rendon that kind of discusses who those people are in this particular command that we can talk to. And we limit that as much as possible anyways. So, but we have a gold team. Are you guys familiar with the gold team idea? Right? The gold team has a coach on it, right? And the coach isn't actually one of the members of that party that's allowed to know a lot of these details. And so if the cadet allows us to engage with that coach, we might. Otherwise, we keep our lips tighter yet, and then only share like really what's necessary with the command, but not content, not the details of your pain, but it would be a diagnosis of you can and can't do this, and you need this or that kind of treatment.
So if you're concerned about documentation, we're obligated to make notes in your medical record, both the primary care docs and myself. But that stays in your medical record. It doesn't enter your service record or your academic record. If you go downstairs and you see Dr. Poplia, she does not make any entries in the medical record because she's considered separate. Does that help?
Yes, thank you.
So your second question, who has access to our medical records? So who would see that information that you document?
And who has access to the medical records and who would see that information? You do. You can access it by request, and by request only because you can't take it back with you, but you can have unfettered access to it. And nobody outside of you, unless they're inside of the clinic, and technically, anybody in the clinic who's walking around has like physical access, in a sense, but does not have the right to go entering into reading other people's records unless they're actually part of the team who's caring for you. And you have the right to know every member of the team who's caring for you in a particular situation. And that should be documented in your record too. So if you come and see me, I'll write down who's seeing you, and the corpsman who's working with me signs your record with us. Does that answer your question?
So St. Class Ashby, I was wondering if there's a maximum amount of time that for either cadets or in the fleet that someone can be on medication for mental health issues.
Is there a maximum amount of time that you can be on medication for mental health issues?
Yes, sir.
No, there's no maximum. Some people are on it most of their career. There is a maximum time people can be on temporary limited duty during a career, and that's 12 months. If it extends beyond 12 months, then we're obligated to write a medical board. But many people are on medication and they're not on temporary limited duty. They can function at their job, and the whole purpose of medication is to get people to be able to function well. Does that help?
Yes.
First question, I'm wondering if, from the cases you've seen with mental health, if, there are ties, like you've seen like the same issue, and that's why, like, say living in Chase Hall, like, most people having mental health issues, if you're able to talk to the command to recommend changes be made so that, the floor is happier.
So let me rephrase your question to make sure I understand you. Have we seen a particular pattern of mental health issues within Chase Hall that might warrant a top-down change in the way that things are done at Chase Hall? The short answer is no. That doesn't mean that the answer should be no. But this is a military training facility, and there are sort of intentional rigors involved, and that's not all pleasant. But when you get out into the military to like get away in your ships, there's going to be other stressors involved as well, and so these are artificial lots of times, whereas in the future they'll be real. And when we want you to be able to survive the rigors of cadet life, and I'll tell you that I've never had more pain in the fleet or in the Coast Guard than I did at the academy. So if you can get to the academy, you can get to the Coast Guard. But I'm not sure, so I can't answer your question very well, because there's not like been a pattern of it. There are always people who have mental health issues. We're always ready to help them, but we're not like surprised or shocked by the volumes of them. Does that make sense? Agree with that?
Yeah, I would say the cadets that I see, most of the issues have to do with them individually and are not systemic or based on factors.
Yes.
I was just wondering, can you talk about like some of the treatment plans that you impose like on cadets that are going through mental health disorders? Because like I've heard a lot of times that like the treatment plans are sometimes to like remind your friends to like have that support system. But how are like cadets supposed to be like there for each other sometimes, but balance obligations of reporting or seeking help, but also trying to support them and not like, you know, handle it all on themselves. Does that make sense?
So you're wondering if they're, would you ask the question briefly? I can fill in the details.
So, I was just wondering if you could talk about like the treatment plans that you guys impose on the cadets
Yeah,
for
okay.
mental health disorders, because oftentimes like I see that's
Yeah.
going like.
Okay, so can we talk about the treatment plans that we sort of recommend for you, given that sometimes that involves like just getting help from another cadet and the whole gamut of like what we require of you or expect of you? Yeah, we can. I think that actually there's three of us who would answer that question differently. So I'm going to pass the mic here in a moment. But we give you and we intend to give you professional help when you need professional help. We never send somebody back to Chase Hall and say, your friends are adequate for a serious problem, or even for a minor problem. If you want professional help, we offer it. And that doesn't mean we're saying, don't go to your friends, don't be supported by friends. We want you to do that. That's like for 100% of the cadets, we want that to be true. And so if there's a perception that we're saying, hey, just go back and rely on CPS, then I think we've crossed wires somewhere. If you're hearing that, we should talk about that. But there are treatment requirements after we diagnose you with a problem, because you need to be fit by the time you graduate. So they're kind of like this helpful, unhelpful relationship, right? You come to us and complain about our problem. It's like, hey, we're happy to help you, but not only are we happy, we have to help you. Like, and we want to help you. And if you're not getting good help, if you have a bad counselor or a bad counseling relationship, or the meds aren't working, you just come back and we'll modify the plan in a variety of ways to get you well. So that's only a part of your question, I suspect. Does that begin to answer it, though?
Yes, it does help.
Do you want to tackle that one?
So when I see a patient, my purpose here is to do evaluations and medical boards and sanity boards and medication management. I don't do therapy for most people. I have them see someone else. So I will lay out the medication management plan if that's appropriate. If the person does not want to try medicine, I don't force them to take medicine. I can't force them. I say, all right, we'll start with the counseling and we'll see how that goes. But if you don't make progress, then we may have to revisit the issue of medication. So we make recommendations about medicine, about seeing a therapist, whether it's here or somewhere else. In some cases, we'll make recommendations about classwork or continuing the full load or dropping some classes, or it depends, again, on the patient. It's very individualized. It's not a cookie cutter process. It's not black and white. We all function in a very gray area, so that's why we can't say if this happens, then that will happen. Because humans are not machines. They're all individual, and we try and craft an individual plan for them.
I just want to jump in on this one quickly. I think there can be confusion between a treatment plan and a plan of overall support and functioning. So there may be times when we're working with a cadet and we talk about what are things, maybe they're seeing Dr. Daly, maybe they're not, so medication might be part of the treatment. But we will tell cadets who may be more inclined to isolate themselves or to not say anything to friends if they're having a hard time. We might say to them, you might want to spend time with friends. Go do things with your friends. Go to the movies. Go and let your friends be your friends. They take part in social activity on campus. We would never tell someone who's in treatment to say, go to your friends if you are having some acute suicidality or you are in a really horrible place, except if your friends are the only ones around, and you say to your friends, can you get me some help? So the friends can be a conduit to that help. That's different than the friends being the help. So in an ideal situation, cadets have social support and friends that they can spend time with and go to the movies and do all kinds of go out to dinner, but not to be providing treatment to them. And so we would make that differentiation that if you're feeling suicidal, if you're having severe depression, where are sources for you? Do you want to talk to us? Do you want to talk to Dr. Daly? Do you want to go to your PCM, the chaplains, a suicide prevention hotline? Those are things that you do when you're feeling suicidal. You go to your friends to let them be your friends. Does that make sense?
Does that answer your question? Yes.
You mentioned risk before, and I was wondering, risk after someone comes back from being evaluated. Especially after a suicide attempt, when someone comes back, how do we, like, with the whole, like, core leaving the core mindset, how do we process and evaluate that risk in fear of, like, pushing someone over the edge of meeting core standards?
Given the gradient of risk, how do you, as a group of cadets, enforce standards? I think I partially understand your question.
Like, in fear of, like if someone comes back shortly, like a short turnaround, they've been evaluated and you're told, hey, they've been evaluated, they're good, but still with that risk, like, how do you go about enforcing the standard on someone after that such short turnaround? Like, with the fear of, like, possibly adding undue stressors and, like, pushing them over the edge.
So you're talking about like standards, like room standards or uniform standards and that
Just
nature
like
of
the
thing?
very basics, like.
Sure, okay. Yeah, because mental health problems aren't an excuse to get out of the standards, right? But sometimes you as a leader need to consider what standards are you imposing to evaluate, like, well, am I gonna push somebody over the edge, right? That's kind of where we're going with that. And when we send somebody back to Chase Hall, we only do that if we think they're gonna be safe enough going back into Chase Hall, right? They're not gonna do that if we think they're unsafe. But you could do something in Chase Hall that's inflammatory and change that whole plan, right? So if somebody's going back into Chase and just like leaving the room in total mess and not putting a uniform on, I think it's totally appropriate to go and hold them to the standard, but it doesn't mean that you bag them immediately, right? Consider the fact that this person is under a lot of stress and come along as a friend, be like, hey, what's going on? You know, and help them before you just bring the hammer down on them. Because I'm gonna say, bringing a hammer down on somebody who's in the midst of a crisis is probably the wrong answer, but doesn't excuse them from the crisis, doesn't excuse them. It's a difficult thing, and I think that you're gonna have to feel that out a little bit as a leader, but we're not sending you someone that we think is gonna kill themselves or hurt themselves just because you told them they had to polish their shoes.
If anyone has to leave for class, feel free to just like step out. I know it's our turn.
Yeah, we'll stick around for a few minutes, but do feel free to get up and go.